may recur once or twice, but generally do not progress to invasive cancer. Whereas the not visible lesions, which only may show clinically areas of redness or described as velvety redness and all that kind of thing, are the source of invasive cancer. And this really was the fundamental observation which we made based on the study of these workers exposed to para-aminodiphenyl. And we had a follow-up information on some of these people and published a paper in the New England Journal of Medicine showing that about 80% of the people who had the invisible lesions of the bladder but positive urinary sediment develop invasive cancer of the bladder. So that was really confirmatory of the story. Now, if you want perhaps the most remarkable and painful example of this knowledge is the story of Vice President Hubert Humphrey. Hubert Humphrey was Lyndon Johnson's vice president during the days of Vietnam War. And one day I got a phone call from Dr. Kash Mustafi, who was then the head of the urinary tract pathology at the New England and the Armed Forces Institute of Pathology, swearing me to total secrecy. He was going to send me some material on a very high official of the US government. And we received the smears and the biopsies on Mr. Humphrey. And we didn't know at that time it was Mr. Humphrey. We found out subsequently that it was. And he had absolutely clear-cut evidence of cancer, and the biopsy showed a classical aggressive carcinoma in situ. Some of this material, by the way, was sent to Dr. John Frost at your institution. He, being a somewhat timid diagnostician, I think he called it Mark-Raytipia or something like that, but it was beyond a shade of a doubt a highly malignant tumor. At that time, we had already studied a number of patients with this disease, and we knew that radiotherapy was not effective. For whatever reason, it's true of many other carcinomas in situ as well. Radiotherapy does not cure, does not kill carcinomas in situ, and I still do not know exactly why. But the treatment for carcinoma in situ of the bladder was radical cystectomy, removal of the bladder. Unfortunately, that was a political year, and Mr. Humphrey became the presidential candidate, as you may recall. And some of us who knew the secret of his illness and couldn't talk about it for obvious reasons were frightened to death that we will have a president of the United States who will die in office of bladder cancer. In fact, he selected radiation because he was then running a campaign as presidential candidate, and as you may recall, he lost to Nixon. But the fear of what would happen, knowing something about the future president of the United States who is going to die in office, was the burden of that was simply unbelievable. And it lasted until the last election. And I don't want to say how upset I was about this whole story. It was extremely upsetting. And I know that Dr. Frost shared some of these concerns. The fact remains that Mr. Humphrey lived for another 10 years. So he probably would not have died in office if his office were only 4 years. But the natural history of the disease became obvious. And about 6 years after the initial diagnosis, he developed invasive cancer, went to Memorial Sloan Kettering Cancer Center to have his bladder removed by Dr. Willett Whitmore, who was a remarkable urologic oncologist. But by then he already had metastasis. He lived for another 2 years and died, I believe, in 1978. So he lived for 10 years from the time of diagnosis, but developed his invasive cancer about 6 years after the diagnosis. It was a very frightening experience. For me, it just shows that sometimes cytology may be an obstacle in the political life of the United States. It was an absolutely remarkable thing. Some years afterwards, a Dr. Sidransky from your institution scraped some of the cells from the smear which was sent to Dr. Jack Frost and discovered that gene number P53, which is the key gene in DNA reproduction, was damaged in Mr. Humphrey's case. And therefore some people started to say, well, you know, if we only had molecular biology at the time of Humphrey's disease, we would have done something different. Not true. I consider this is just an unnecessary angle on what was perfectly obvious on purely morphology grounds. We made the diagnosis, we recommended the treatment, we were not followed in our recommendation, and then the consequences were obvious. Fortunately, they did not affect the politics of the United States.
I believe those cells that were scraped off the slides that originated at Hopkins were slides that were made 4 or 5 years before the diagnostic biopsy.
Yep.
And so the thing that Sidransky was trying to prove was that those cells that had been read as highly abnormal indeed had the same P53 mutation as the biopsies did, which were then invasive cancer.
That is absolutely correct. We have done some other studies of similar type, and there's remarkably DNA in smears or in biopsies is very well preserved, can be easily extracted and studied, and we have done that as well. So that was the story of my interest in urinary cytology is now, I think, quite evident. And there were, however, some other issues about the organ which were very, very interesting to me. And one of them was that the structure of the epithelium of origin of these carcinomas in situ and things like that, and the structure was really very different from any other epithelium. One has to realize that urine is a poisonous liquid, and it's contained within the urinary bladder, sometimes for many hours and sometimes even for days, without causing uremia. So there must be a mechanism that protects the bladder and the organism from seepage of urine across the epithelium. And that's when we started studying the epithelium lining the urinary bladder. It's known as the urothelium today. And it found out that it has a very, very different structure from any other epithelium in any organ in the body. It's absolutely unique. And I called it the urothelium. And I think the term has now been accepted by many people, the urothelial tumors, rather than using the old term transitional cell tumors. There clearly is a very definite structural difference, and that has been further confirmed by a group of investigators from NYU who identified a number of proteins in this epithelium which they called uroplakins. The uroplakins are absolutely unique to this epithelium, and they use the uroplakins for a variety of investigations which I don't really have the time to discuss now. But it's a unique organ, unique behavior, unique cancers, and unique clinical significance. And that's what made me so fascinated by it.
I agree. It is a Very fascinating body site. Let's go back to the concept of two separate types of urothelial lesions. In the 5th edition of Diagnostic Cytology and its Histopathologic Basis, on page 739, you tell us that, quote, "The problem with cytology of the urinary tract is the lack of basic understanding of the accomplishments and limitations of the method and of the pathologic processes accounting for it." Could you elaborate on that for us, please?
I'm not quite sure. Much of it has to do with urologists who are very upset if they have a patient with no visible lesion and a positive smear. They cannot quite, just like these physicians from St. Louis, when we were doing the